Hi, Felix. How are you?
Yeah, fine, thanks.
Everyone get ready, right? Hi, Seva.
Hi.
Go.
Okay, we just wait for Dr. Lee to come in.
Hi, Gopi.
Hi, how are you?
Okay, I'm fine. I'm fine. Chennai is not very big. Huh? Chennai is.
I think your place is much better.
Well, still everyone can't go away. Still in Hong Kong.
We get about 1,200 to 1,500 cases per day.
Oh,
That's not the state, it's only my city.
Oh dear.
Yeah, Tamil Nadu state gets about 3,500 to 4,000 per day. The second leading in India.
I see.
The first is Mumbai, Maharashtra, next is Tamil Nadu.
That's all right. Americans still got the first place.
Oh, I thought that you were doing 3,000 to 4,000 cases of HIFU a day in your hospital.
Oh.
Can we start? Ready? We start?
Okay, get ready to start.
Sure. So again, good morning, good day, or good evening, wherever you are. Today we are hosting episode 3 of the APAGE ISMIVS HIFU session or forum. I'm a chairperson, and assisting me, before that, just to read, we are in the 9th today, the third session, 9th of July. Assisting me, my co-chair is Dr. Yuen Pong, a very good friend of mine. Pong, myself, and Professor Lee Chilong met in year 2000 in Singapore, and we just sat down and mooted this idea of forming an association so that Asians can present their work and the research on an international platform. I think so far we have been doing well, and it's growing in size, in numbers, and in interest. So Pong will be my co-chair. Share a little about Pong. He's currently the director of minimally invasive gynecology at Hong Kong Sanitarium and Hospital in Hong Kong. He's also the honorary consultant of the hospital and honorary clinical associate professor of the Chinese University of Hong Kong and University of Hong Kong. He was a consultant and head of gynecological endoscopy in Department of ONG, Prince of Wales Hospital from 1997 to 2007. He was also the founding member and past president of the Hong Kong Gynecology Endoscopy Society and the Asia Pacific Association of Gynae Endoscopy, which is APAGE. So he's actually a past president of APAGE. Without further ado, I will hand you over to Pong, who will introduce our next expert panelist, Dr. Gopinath. Over to you.
Yeah, welcome to the P.M.Gopinath, this expert panelist today. Dr. Gopinath is the director and senior consultant of the Institute of OBG and IVF, SRM Institute of Medical Science in Chennai, India. He is currently the Vice President of Fertility Preservation Society of India. He is also the member of International Fertility Preservation Society, the Chairman Board of Studies, TNDR MGR Medical University. He was awarded the leading lights in the field of reproductive medicine in Fertility Vision 2018. He has published many international and national publications. His special interest in is in infertility, laparoscopy, hysteroscopy, and preservation of the fertility. Welcome, Dr. Gopinath.
Thank you.
Okay. Just a word. I am chairing this meeting in Singapore, and the control room is actually in Chongqing. So there may be a delay as we move from speaker to speaker, so please bear with us. In this series of webinars, I'm also choosing a selection of very skilled surgeons so that every one of you can brainstorm with them, pick their brains on their skills, their thoughts, and modification of HIFU protocols to suit the practice. So now, just to remind everybody, the series covers HIFU, high intensity focused ultrasound. In China, they call it FUAS, which is focused ultrasound ablation surgery. So they're interchangeable. This is the machine we are talking about, HIFU, which is, I call it the virtual knife. And the knife, the ultrasound knife actually comes out from the bottom of this bowl, and the patient lies on top of this machine. And this is brought to you by two organizations, APAGE and ISMIVS. Okay, APAGE stands for Asia Pacific Association of Minimally Invasive Therapy and founded in 2003. Let's take a walk down memory lane. Picture of the APAGE members in 2003. I think you know most of them. That's Professor Li Shilong, Harry Rich, President-elect Prashant, and the very young Dr. Yuen is behind with all the other delegates from Korea and Japan. This is Pong giving me a memento in the APAGE Hong Kong in 2005. And this is a picture of Professor Felix Wong and myself receiving the Lifetime Achievement Award in Japan, Okayama in 2017. And I'm very happy to say a Lifetime Achievement Award given by APAGE is not a retirement award. I dug up this, was very casual, drinks with, in year 2000 with Felix Wong, myself, Hayashi, and I can't remember his name, but this is Pong. And one of these reasons why I want to host this is to introduce our very expert Asians in the world of laparoscopy or hysteroscopy. And not many people know Hayashi actually Professor Lin Baoliang. He works in Kawasaki. And right now, and I still believe, just in 1985, he has done 22,000 flexible hysteroscopy. And the last count in June, last month, 2020, I think he has probably done the most in the world. He has done 6,990 resectoscopies, operative resectoscopies. So I think this man needs mention because he's a very quiet person working in Kawasaki, Japan. And if you come across things like Lin's forceps, Lin's instruments in hysteroscopy, this is the man. And you should actually, you have a chance to watch how he operates, how he does his hysteroscopic surgery. That is Professor Lin Baoliang or Hayashi. This is a picture taken recently in 2019. Again, myself, Pong Mo, Professor Li Shilong, and this is a very, very great teacher in sort of a military uniform. He's actually Professor Lang Jinghe, the chairman of KOGA, and he has a membership of 160,000. He's past president of APAGE also. He's a great teacher, a painter, and you should listen to his lectures, philosopher, his ideology. And if I have my wish, I would love to translate his lecture on adenomyosis from Mandarin to English for you. It is the new treatment of how his view of adenomyosis began to what it is today. That is Professor Lang Jinghe. This is Professor David Cranston. He's a surgeon, but he is instrumental in getting HIFU into the books of NICE, NICE, to be accepted as a mode of surgery for fibroids. We must thank him for this. And this is his group of advisors, a very huge group. Picture taken in 2017. I know I've introduced all these members to you before, but he's going to speak later on. This is their biannual meetings, and when they have a meeting, it's in the thousands. And what's important to note is in July 12 to 14, 2019, APAGE and ISMIVS signed an MOU with regards to HIFU training, education, research, and most important is certification. This is important because HIFU is really very skill-based, although you're looking at the machine, but it is really, really, really skill-based. And I think certification is very important. Recap, there are two different versions of therapeutic HIFU for benign uterine tumors. One is MRI guided. If you go on the website or search, you'll probably be diverted to the MRI guided HIFU, but please take a note and look for the ultrasound guided HIFU, which is more ablative. Why? Because the procedure can be done by gynecologist, surgeon, or radiologist, or any trained doctor. The duration of ultrasound HIFU is independent of the MRI machine, so your MRI can be put to better use. Okay, let me introduce the first speaker, who's a longtime friend and a laparoscopic surgeon in Malaysia and Asia as well. Let me get the CV. Okay. Dr. Salva, obstetrician and gynecologist and a specialist in reproductive medicine at the private hospital in Malacca, Malaysia. He heads the O&G unit and the IVF center at the hospital. Dr. Salva received his initial training in laparoscopic surgery under the guidance of Professor Song Hui-Yong. Now, Professor Song is the boss of Professor Li Qilong at Chang'an Memorial Hospital, Taipei in 1994. Dr. Salva is the past president of APAGE. He's the past president of O&G Society of Malaysia and currently chairs the endoscopy subcommittee and is involved in promoting gynecology, endoscopy surgery in Malaysia and in the region as well. A lot of people know Salva. He is a very learned guy and has this energy to teach and learn. So without further ado, Salva's topic, uterine rupture after myomectomy and caesarean section. I chose this lecture because it is the way he gives the lecture, and his treatment of the subject is quite different from what we have heard of so far. So Salva, over to you.
Thank you, Dr. Lee. Can you hear me? I will start sharing the screen. Okay. Whye, can you see?
Yes.
Yeah. Okay. Yeah. I'll move on with the lecture. Okay. Firstly, let me thank Dr. Lee and APAGE and ISMIVS for giving me this opportunity to speak on this topic. I actually spoke on this topic 2 years ago during the RCOG meeting in Singapore. So what I'm going to speak is myomectomy and risk of uterine rupture in pregnancy, a review of the evidence between laparoscopic and abdominal approach. Of course, I'll touch on caesarean section as well. I think Professor Bernard Chen and Dr. Bay has touched about this topic 2 weeks ago. So I may overlap with what they have they have spoken, but I will concentrate on just uterine rupture in this lecture. So I approached this topic with about 7 questions. These are the questions that people usually ask. First is, what is the difference between performing myomectomy laparoscopically compared to abdominally? The second question is, what is the risk of uterine rupture during pregnancy in general? The third question is the incidence of uterine rupture in pregnancy higher with laparoscopic myomectomy compared to abdominal myomectomy? Fourthly, what is the risk factors causing uterine rupture in pregnancy after myomectomy? Fifth is, can we prevent uterine rupture in pregnancy after performing myomectomy? And lastly, how long after myomectomy, laparoscopic or abdominal, is pregnancy safe? I think these are the common questions, and I'll try to look at the literature and answer these questions. Now, the first question is, what is the difference between performing myomectomy laparoscopically compared to abdominally? Now, the classic surgical technique used for abdominal myomectomy was described by Berkeley and Bonney in 1911, and they used a scalpel to make the uterine incision, the suture ligation of bleeding vessels in the myometrium, and interrupted mattress silk sutures to obliterate dead space in the myometrium and achieve wound closure. I think all of us who are watching this have done this surgery. I just want to remind you all, just to show you all that we all do this surgery, maybe slightly differently from others. I don't use a scalpel, but I use quite a little bit of diathermy to try and shell out all these fibroids. And this is what I'm doing. I'm not teaching you all how to do open myomectomy, but just to remind us how we do open myomectomy as compared to laparoscopic myomectomy, and what are the difference in these techniques, so that we will then look at what is the difference in things like wound healing between an open myomectomy and a laparoscopic myomectomy. And here, this patient had multiple fibroids and she's subfertility, so I decided that this surgery should be done open. And so all these fibroids are removed. There are altogether about 30 fibroids in there. So the next question is, how is laparoscopic myomectomy performed? Now, basically, what we do is the first laparoscopic myomectomy was described by Kurt Sam in 1979. More electrocautery is used to cut the uterus and coagulate the bleeders. And suturing is one layer instead of multiple layer of suturing. This is when we first started. And probably now we're all doing more multiple layer suturing. And this is a surgery that I just did some years ago. And so these are just a single, probably type 3 fibroid. So the cavity was entered during this surgery. And so the suturing is done. First layer is to take part of the endometrium and closing it using a 2O polyglactin suture. And so this surgery is done suturing in multiple layers. So the first layer is closed, and then the second layer is usually done to close this first layer, to cover this first layer. And generally, I use a polyglactin 1 suture, a stronger suture for this. And people do in single layer, multiple layer. So I usually prefer to do it multiple layer, just exactly how I will do it in an open surgery. So this is being done. And as you see, at this time, I was not using barb suture. This is a traditional suturing technique. And so the second layer is then closed. And then next layer will be the serosal layer. We can close the serosal layer in many ways. We can use figure of 8 interrupted sutures. We can use continuous locked sutures, but here or what we call as inverted sutures. And here I'm doing subcuticular suturing to make it look nice, and the suture doesn't actually is revealed outside. So this is subcuticular suturing of this serosal layer. So we do this surgery in different methods, but the aim, of course, is to obliterate any dead space and to oppose the serosa so that wound healing will be good. So this is the end of the surgery, and usually we put in some anti-adhesions just to prevent adhesion. So this is how laparoscopic myomectomy is done. I show these two videos to look at the evidence. So what is when we compare these two surgeries, these two types of surgeries, myomectomy and hysterectomy, how do we do it? Okay, let me just move this down. So this is a study that comparison of intramural myomectomy scar after laparotomy or laparoscopy. Now, 1 second. Okay, the uterine scars were tested in abdominal and laparoscopic myomectomy. They were examined at subsequent cesarean section by this study, which is an old study done in 2004. And after abdominal myomectomy, the scar were similar thickness to the normal myometrium. In contrast, the scars after laparoscopic myomectomy are strained, had poor defined edges, and were more contracted and thinner than normal myometrium. This is based on this study. And the authors concluded that these differences were likely due to the use of sutures to achieve hemostasis during an abdominal myomectomy, whereas bipolar coagulation was used during laparoscopic myomectomy. As I said, this is a study that was done in 2004 when suturing skills were not that great. I think it would be much better if the study is done now, probably similar. So the resultant thermal damage to the myometrium induces proliferation of connective tissue which cannot remodel during pregnancy. So that may be the reason why they saw the differences. So that's how the difference between performing laparoscopy, myomectomy, laparoscopically and abdominally. So the next question to ask is, what is the risk of uterine rupture during pregnancy in general? So what is the prevalence of uterine rupture? So in an unselected pregnant woman in a community-based study, this is for cesarean section, the rate of uterine rupture is calculated to be between 0.02 to 0.30% with a median of 0.05%. If we do unselected pregnant women in a hospital-based study, the rate of uterine rupture during pregnancy after is 0.01 to 2.90 with a median of 0.31%. This is for cesarean section. And in women with a history of previous cesarean section, the rate is about 1%. So this is what we are comparing with when we are doing myomectomies. So the next question is the incidence of uterine rupture in pregnancy higher with laparoscopic myomectomy compared to abdominal myomectomy? This is the question commonly asked. Now, there are many case reports on uterine rupture after laparoscopic myomectomy. Here you can see these case reports that starts with in 1995 and then goes down to quite recent 2004, 2002. And here are more recent reports. Here's a report of 7 uterine rupture cases after laparoscopic myomectomy, an update of the literature. Uterine rupture after laparoscopic myomectomy, 2 cases. Here, uterine rupture after laparoscopic myomectomy for removal of a pedunculated myoma, and spontaneous uterine rupture at 27 weeks of pregnancy after laparoscopic myomectomy. So someone actually grouped all this together and did a meta-analysis. And I will just review this meta-analysis to answer that question, whether the uterine rupture what is the rate of uterine rupture after laparoscopic myomectomy and open myomectomy. So this is the result. It's a very complicated result here. And what I'll do is I'll break the reports down for you all. Okay, so the first result is that within this 3,685 pregnancy, there were 29 cases of uterine rupture, a reported result of 0.79%, 1 during labor and 28 prior to onset of labor. So there was a trend for an increased occurrence of uterine rupture following laparoscopic myomectomy. There were 24 events out of the total amount, which is 1.2%, versus 3 events in 705 cases, that is 0.4%. But the differences were not found to be statistically significant. There was 1 case of uterine rupture after hysteroscopic myomectomy. 1 case of uterine rupture during labor, but the mode of myomectomy was not known. And of the 28 ruptures occurred during pregnancies between 17 and 40 weeks of gestation, 80% of the ruptures occurred between 28 and 36 weeks of pregnancy. So continuing on, out of the 400 women who attempted vaginal birth after laparoscopic myomectomy, a large majority, that is 373 women or 93%, eventually experienced a successful vaginal delivery, while only 7% were delivered by cesarean section. Out of the 124 women who attempted vaginal delivery after a myomectomy by an open approach, 109 or 88% delivered by vaginally compared to 15 or 12% who needed to be delivered by secondary cesarean section. So there was no significant difference for the risk of secondary cesarean section after a laparoscopic compared to an open myomectomy. So if a patient have undergone laparoscopic myomectomy or open myomectomy, if you have decided for the patient to have a vaginal delivery, their success rate for achieving a spontaneous vaginal delivery is about the same. Now, just over 50% of the fibroids removed that lead to uterine rupture, the uterine wall, and subsequent pregnancy were localized in the intramural part of the womb, which is 54%. The median size of the fibroid was 5 centimeters. And the study, they found no clear correlation between the risk for uterine rupture and location of the fibroid and the suturing technique, whether the operations were done in the universities or in a non-university hospital. So there were 8 neonatal deaths following the uterine rupture, 5 for laparoscopy and 3 for open surgery, and there were no maternal deaths. So in the discussion, what they said is that the prevalence of uterine rupture following myomectomy, all types of surgery, was 0.79%, which is comparable to after cesarean section, which is about 1%. There is no significant difference between the incidence of rupture during pregnancy following laparoscopic, which is 1.2%, versus open, which is 0.4%. And a higher primary cesarean section rate after laparoscopic than open myomectomy. So many people who do laparoscopic myomectomy just decide to do an elective cesarean section as opposed to open myomectomy, because probably fear of litigation probably. But if they allow them to go into vaginal delivery, their success rate is the same. So as you can see here, uterine rupture in women following myomectomy almost exclusively occurs during pregnancy and very exceptionally during active labor as opposed to prior cesarean section. We all know that the uterine rupture in cesarean section, prior cesarean section, occurs during labor as opposed to myomectomy. And this is explained because of the site of the surgery. As in most myomectomies, the surgery is done on the body of the womb, which is the corporal part of the womb, as opposed to the lower segment in the case of a cesarean delivery. There is also no significant increase in risk of secondary cesarean section after laparoscopy compared to open. Attempts at vaginal birth seems equally highly successful following laparoscopy or an open myomectomy. So there's only one case of uterine rupture that occurred during labor, but the details of that myomectomy was not known. It was believed that there was a high dose of oxytocin used in that particular case. Only a small number of uterine ruptures indicate no clear evidence on location and size of fibroid that lead to uterine rupture. So this I will come to in a little while. And there's no relationship between use of suturing technique and uterine rupture. So most uterine rupture, as I said earlier, occurred in the mid-trimester of pregnancy. So you can see that to answer the question, is the incidence of uterine rupture in pregnancy higher with laparoscopic myomectomy compared to abdominal myomectomy? It appears that there is a tendency towards higher, but it was not statistically significant. So let's look at the next question. What is the risk factor causing uterine rupture in pregnancy after myomectomy? So this is a paper that looked at this question, risk factors for uterine rupture after laparoscopic myomectomy. And they reviewed 19 cases of uterine rupture after laparoscopic myomectomy. They studied these cases in detail, and they found that the myoma was removed and it ranged from 1 to 11 centimeters. The mean is 4.5 centimeters. One woman had 2 small myoma removed, both 1.2 centimeters. All other women had only 1 myoma that was removed. And 13 procedures, the uterine incision were made using monopolar electrosurgery. 2 surgeons used bipolar scissors, 1 used cold scissors, and 1 used ultrasonic scissors. And in 5 cases, the endometrial cavity was entered. This is important, okay? Out of the 19 cases of uterine rupture, only 5 cases had the uterine cavity, endometrial cavity entered. And hemostasis was done using monopolar electrosurgery in 6 cases, bipolar in 7, bipolar and suture in 3, and sutures alone in 2. So the uterine defects were closed with only in one suture in 3 women, 1 layer of sutures in 4 women. 1 woman had only the serosa that was closed, and uterine defects were not closed in 3 cases, and multi-layer closure was done in only 3 cases. So what did they conclude from this study? They said that we should use limited use of electrosurgery and multi-layer closure of myometrium except in superficial uterine defects. and the effects of the carbon dioxide pneumoperitoneum on the wound healing, and an understanding of the individual healing characteristic related to the production of growth factors or expressed collagen disposition is also necessary. So this is something that has not been resolved yet, whether carbon dioxide pneumoperitoneum actually affects wound healing. And even in ideal surgical technique, individual wound healing characteristics may predispose to the uterine rupture. So we don't know what is the ideal surgical technique. So now I've looked at the risk factors causing uterine rupture, and what you can see is that we cannot identify the exact risk factors. Some people say that if you enter the uterine cavity, you get higher uterine rupture, but that is not shown in this particular study. So the next question is, can we prevent uterine rupture in pregnancy after performing myomectomy? Now, there is no studies that looked at this, and I don't think anybody knows how to prevent uterine rupture in pregnancy after performing myomectomy. The general consensus is if you don't enter the uterine cavity, you will have less uterine rupture. That was been disproved by this particular study that I showed earlier. Perhaps by shrinking the fibroids using HIFU may be one way of preventing uterine rupture, and probably all our experts will be discussing about that in a little while. The last question I would like to ask is, how long after a myomectomy, laparoscopic or abdomen, is pregnancy safe? This is a favorite question. Everybody asks this question, and I try to look at the literature to answer this question. So this is the first paper, which is a post-myomectomy sonographic imaging, uterus remodeling and scar repair. This paper was published in 2009. And here they did an ultrasound evaluation of the abdominal myomectomy scar performed 60 to 90 days after surgery. And they found mixed echogenic areas thought to be the result of hyperplastic myometrium, small hematoma, and suture material. And there was a gradual shrinkage of the myometrium, resolution of the hematomas, and absorption of the suture materials that led to a decrease in size of the scar over 3 months. So this particular paper says that probably 3 months is the time when the scar will completely heal. This is another study, MRI evaluation of the uterine structure after myomectomy, published in 2006. Using MRI, they looked at the uterine structure after a myomectomy, and they found that the uterine healing process was complete in 12 weeks after abdominal myomectomy in the absence of hematoma or edema formation in the myometrium. This is the last paper, evaluation of post-myomectomy uterine scar, and this is published in 2005. In this study, they used ultrasound, a preoperative myoma greater than 10 centimeter, and experience of the surgeon was significantly correlated with the formation of uterine scar hematoma. So this is what we are trying to prevent, uterine scar hematomas causing weakening of the scar. And if the uterus, the fibroid is bigger than 10 centimeters, and an experienced surgeon will probably have a lesser chances of having a uterine scar hematoma. And so they also concluded that wound healing seemed to be complete within 3 months. So to answer that question, 3 months seems to be a figure that seemed to be the figure to say that the uterine wound is completely healed. But I think many people will add another 3 months and say probably 6 months will be a safe time. So in conclusion, I have looked at 6 questions. The first question is, what is the difference between performing myomectomy laparoscopically compared to abdominally? You noted that the way we do the myomectomy probably previously is different from now. We are doing our laparoscopic myomectomy more similar to that of open myomectomy by using suturing with less usage of diathermy. And so the wound should heal about the same as that of an open myomectomy. The risk factor of uterine rupture during pregnancy is about 1%. The incidence of uterine rupture in pregnancy is higher during laparoscopic myomectomy compared to abdominal myomectomy, although this is not true by the studies, although there's a tendency to be higher with 1.2% with laparoscopic myomectomy and 0.4% with abdominal myomectomy. We looked at the risk factors. Out of the 19 patients, they noted that the risk factors, they couldn't find anything that pinpoints something as a risk factor for uterine rupture, even entering the uterine cavity. There's nothing that we can do to prevent the uterine rupture. and how long is the duration for allowing pregnancy is probably more than 3 months, probably 6 months. Thank you. Back to you, Dr. Lee.
Thank you. Can you hear me, Salva?
Yeah, I can. I'll stop share now.
That's the reason. That's the reason why I chose you to repeat your lecture again, which I thought carries a lot of clinical valuable points, especially to the younger colleagues of ours. Bearing in mind, like what you've said, a paper that is written 20 years ago, 10 years ago, are always quoted by younger colleagues, especially when they're going for exam. But out in the everyday world, we have to be mindful of the fact that the standard of laparoscopic technique, the facilities that we use now, and the medical legal implications which all of us faces will have an impact of whether we advise our patients to go on VBAC, which is vaginal birth after cesarean section, or to go for to offer them first choice as a cesarean section. And I think these are valuable lessons to learn. And I'm going to go around the table later on after all the speakers. But thank you so much, Salva. Thank you. Now, the next speaker will be introduced by Professor Yuen Pong Mo. Pong Mo, over to you. Can you take over and introduce the next speaker?
Yes, sir. Thank you. Our next speaker is Professor Felix Wong. I'm very glad to introduce him because he's actually one of my mentors when I started doing the ONG in Hong Kong. He's actually the co-joint professor of the University of New South Wales in Australia. He's currently the chairman of the China-Australia Asia-Pacific Association of Minimally Invasive Gynecologic Oncologists, and also the foundation chairman of the China-Australia Asia-Pacific Forum of Minimally Invasive Surgery. Professor Wong is renowned for his contribution to the medical education in the Asia-Pacific region, and he has actually received numerous awards from different places. To name a few, one of these is Guangdong Friendship Award in 2003, Endoscopic Award in 2009, 2005, Medical Ambassador from the Gynecologic Endoscopy Group of the Chinese Medical Association, Ho Chi Minh City Badge Award in 2006, and the Endos Award in Medical Science and Technology in 2009. So I guess most of people actually know Felix very well. I think without further ado, we should ask Felix to start his talk. He's going to talk to us on something different area, which is on the HIFU in the Hong Kong SAR, and also the potential of the HIFU. Professor Felix Wong.
Felix, over to you, Felix.
Okay. Thank you, Bomo, for introducing me. And I want to share my presentation here. Can people see my presentation?
Not yet, not yet.
Not yet. Okay. Yeah. Good night. Good evening, everybody. I'm going to share my my little experience in focused ultrasound, my experience in Hong Kong, and talk about the potential of the focused ultrasound surgery development. I'm proud to be with this group of APAGE, and we have achieved a lot at Professor Professor Lee have said, is that we have our own journal, we have meeting every year, and we have workshop, and I'm proud to be involved with this webinar meeting. Now, like Professor Lee have said, we went to China for meeting and we learned about focused ultrasound surgery. There's the HIFU at the meeting. And we started to form interest in this type of surgery. We find there's a new surgical direction. Of course, it won't earn you a Nobel Prize. That changed the medicine. But we did find that there's a new surgical direction, which just like in those days when we are starting the minimally invasive surgery. The clinical advantages of the focused ultrasound surgery are now well recognized. There's no bleeding. It doesn't use a knife to cut. We conserve the uterus. There's the organ that's important. And most impressively is the patient go home. The next day, for us in Hong Kong, they go home the same day. So the effectiveness, when you look at various journals, and the more you look at it, the more in the literature, the more journal, they report the use, the effectiveness of HIFU in our gynecology. For example, this well-known multi-center trial published in 2018 by Professor Lang, and it's a so-called ideal study. It compared the hysterectomy as well as myomectomy with HIFU. There are also many studies from various journals, like Journal of Minimally Invasive Gynecology, like Journal of Hypothermia, and not only talking about the effectiveness of HIFU compared to laparoscopic myomectomy in fibroids, showing that it's more effective and more safe, and also quicker recovery that's well recognized. Not only that, the ovarian function, the sexual function of the HIFU comparatively it's better, especially shortly after surgery. It changed the concept of our surgery. Instead of multi-doctors doing the operation, a single doctor can operate. Instead of the patient put to sleep, knowing nothing about the surgery, you can see the patient is talking to the nurse very comfortably. Of course, knowing that there's such a new surgical approach, one will not miss, have to visit the center in Chongqing called HIFU Company. You'll be impressed by some of the facility there, especially this site, where you can see a big screen showing that various centers operating HIFU surgery being supervised by the experienced staff there. And they are monitoring some center doing the HIFU study. So they are not only selling the machine, they are providing education to many of the doctors who want to learn. And I have the chance to talk to the engineering and the inventor, Professor Wong, and about the machine, about the good points, and about various things, learning about the surgery. I was lucky to be able to travel to China very often. You see, these are the places where I have been to, where each of the center operate more than 500, even up to 1,000 cases nowadays a year. So these are the center in Chongqing, in Shilin, in Guangzhou, in Shanghai. There are so many places now in China. They are operating so many cases in gynecology for fibroid adenomyosis. I was lucky to be able to learn this new surgical technique and with the experienced doctor. As you can see, when I learn all this technique, I found that the patients are enjoying themselves looking at the iPhone. So quite different from what we are doing, even we are doing a wonderful minimally invasive surgery. So when I came back to Hong Kong, starting to look into build up the center in Hong Kong with great difficulty. After a while, you can see I set up a center in the commercial area, just you have just seen. And this is my center in Hong Kong, just a quick video to show the inside of my HIFU center. So a simple room of around 300 square feet you can have the room like that to operate on the patient. Not only that, I will be able to use the facility to teach the doctor who don't know how to operate HIFU and come to either sit next to me or sit outside when there's too many people. They are watching the screen, the same screen what I'm looking at, and they can see through a one-way glass, and so they can operate and see how we operate inside the HIFU center. Inside the center, not only I have patients and doctors learning from me, I also initially set up a 360-degree camera, which I'm using the Zoom, hopefully, allow people outside to watch what I'm doing. That's what I'm proceeding for the using the internet platform to teach. For people who are interested, you can go to the journal of our APAGE. There's the Journal of Gynecology and Minimally Invasive Therapy. Early this year, 2020, I talk about the facility and the setup of my HIFU center. Now, also you will see I have different color in the center. It seems that certain color make the patient more comfortable. Also, you can see that my center allow not only the patient, my doctor to come in, their relatives are coming in to join them. I'm confident that this surgery is so non-invasive, the relative won't stop me from operating, because when they see what I'm doing, they are convinced that this one is the daughter are safe in my hand having this surgery. You can see this patient holding an iPhone, just like what I have learned from other centers, that the patient, when they are awake, they can do what they want to do, talking to friends, but I don't want them to do that. It will sometimes they move. Now, so my center is different from others that we don't have any blood loss because of this non-invasive surgery. There's no need to a large storage room and for our changing, because no change room required. Doesn't need to a male, female change room, and doesn't need a storage space for the instrument we are operating. So we don't need a sterilization room. The most important later on, what I'm talking about is the no medical waste. In those days, before I started to work with HIFU surgery, and what we learn about pathology is when we remove the uterus, we cut it open, we say, wow, there's the adenomyosis we are dealing with. But now, because the HIFU in every patient, we did the MRI, we know exactly how many fibroids they are, how big they are, and why we may fail in some of the surgery and why we may fail in my HIFU surgery. We know more about adenomyosis. These are the diffuse adenomyosis or nodular adenomyosis. We learn much better about the pathology of fibroid and adenomyosis. So we're starting to make diagnosis of fibroid adenomyosis with MRI. In earlier days, because we are just starting new, patients learn about HIFU, non-invasive surgery. Those patients who doesn't want to operate have a very big fibroids, or our doctor refer us those patients who they couldn't operate and to come to have HIFU treatment. You can see there are some patients with multiple myomectosis, multiple fibroid, a fibroid of 15 centimeter. Now I'm working in a clinic that doesn't allow patients to stay for 24 hours. And in some of these patients, in our early cases, we have not have to operate on them. I was told you better be careful when you set up the surgery, and there's a new approach, and the word of warning is be careful. There could be shark around waiting. So over the 9 months when we first started in September, year 2019, and until June the 20th. You can see in Hong Kong, we have the problem of social unrest. And when we're starting to think we are better, and the coronavirus is coming. So you can see we are under great difficulty, but we never stop. Despite all that, patients still come. Even the hospital are closing because of the virus. People still coming. Now, so I cannot share with you because of a small number of cases, my experience, but I can tell you that I'm proud to be able to provide a service for some of the patients. Now, there's one patient, for example, this young lady of 31, she's an athlete for Hong Kong, and I operated on her 5 years ago for myoma, which is 8 centimeters. 5 years later, she had a recurrence of the fibroid with heavy bleeding, and the fibroid reached 9 centimeters. Because she is a sports woman, she can't take any medicine or some medicine that may be affecting her sports. And she was also ready for another competition, even though I can perform another myomectomy for her, but she rather try this HIFU surgery. And this the MRI before the operation is around 9 centimeters, 9.5. And then after four months, 9.8. After 4 months, another MRI showed that it's already shrunk to 6.5, and her bleeding become normal. Her mother is quite pleased during the surgery when she received this HIFU surgery. Another successful example is for adenomyosis. And this lady with a big adenomyoma, with diffuse adenomyoma, she had pain score of 9. And after HIFU treatment, 4 months later, the activities of the adenomyosis have already disappeared. Her pain score is 0.5. She's quite well, and she really enjoyed having this. At least for the 50 cases I've operated, I saved the uterus, or my team, not just myself. So they have adenomyosis, they have fibroid, and they all have the operation done. Now, not only that, we do have patients to come to us because my colleague won't operate on them. And there's another lady with cerebral vascular accident, carotid artery thrombosis. That's 9 months ago, and due to overtaking of a estrogen continuously for a few years, and then she developed thrombosis in the artery. And nobody want to operate on her because of the risk of perioperative stroke. So after 9 months, when the risks are low, I offer her the HIFU treatment. She was all right after overnight stay in the hospital. So she's very pleased. She was very pleased with the operation. Nevertheless, I mean, there are cases of possible failure despite my small number. For example, this lady with adenomyosis, she received already 3 months GnRH. You can see the activities of the adenomyosis is much less. Despite my HIFU treatment and another 3 months of GnRH, when I stopped the GnRH 4 months later, despite she said the pain score is much better, but I can see the activities of the adenomyosis starting around the endometrium. Another lady, successful treatment. However, I would expect she will have a recurrence because it seems that surrounding those ablated area, there are activities going on. Again, despite the treatment have been successful, it's incomplete in this lady. Now, to further develop the HIFU treatment, the future of HIFU treatment in gynecology, in my opinion, I think this non-invasive surgery will be welcomed by many of our patients. We need to make sure that it further reduces the risk to our doctors and our patients from the conventional surgery. Now, more important is the need to improve our safety, the safety of the patient and the effectiveness of the focus surgery, as well as expand the use of HIFU in cancer, benign cysts, and other applications. Finally, it's really the impact on environmental. I'll briefly, quickly going through this. We all know during surgery, we may cut our hands. That's our risk. We may risk of HIV and hepatitis. This we all avoid by having focused ultrasound surgery. This too, we present a cricketer with myomectomy. We sometimes have heavy bleeding, risk to the patient. Then we also avoid. Now, how about the safety of the patient? Can the target? I'm sorry for those who have not operated on HIFU, but I hope they understand that this MRI scan, usually ultrasound have difficulty to see where the extent of the fibroid, where is the endometrium. For young lady, when we want to save the endometrium, don't want to burn it, the incorporation of the MRI pictures onto the ultrasound will help us a lot to know where we target at, how far away we are from the endometrium. Now, in this way, we can help to save the patient from endometrial damage or the damage of the brow when we are too close to the brow. So the development of this MRI incorporated in our HIFU ultrasound pictures is very important. The important thing, however, is nowadays is still manual to be able to adjust it. So with development of artificial intelligence technology, I think the automatic targeting and the tracing of the ultrasound pictures by MRI pictures will be feasible. So with more 3D development, we will be able to see each segment of the fibroid that we are burning. We can see exactly how many, for example, using microbubble, able to label each of the layer. We can see which layer, which are the area we want to target from the ultrasound, because ultrasound will be very difficult to find which area you are still weak, have not been able to ablate. Now, skin burn is another area that we worry about, and we worry about the nerve being burned and the overheating. Now, one of the monitoring I'm using, you can see, is infrared. When area that is overheating, and it will be alert by the tracing. And I find that patients, when they reach a high temperature, over here, there's a high temperature up to around 37 to 40, patients starting to complain of pain, sometimes nerve pain. Now, for the 50 patients, while I'm monitoring with this infrared, there have not been anyone who have nerve problem or skin burn problem. And not only that, I'm working on the research area to calculate the algorithm, trying to locate, reflect the internal temperature using infrared monitoring and other device. So hopefully will be just like MRI guided HIFU will be able to assess the internal temperature that will avoid burning the bowel and the nerve. Now, the other thing is the effectiveness of the HIFU for the time being. We are monitoring the using ultrasound guided. You can see the grayscale changes when we are hitting on the fibroid. And in order to assess whether we have completely ablated the percentage of ablation of the fibroid, we use microbubble. Now, for those who are not using learning HIFU, the microbubble is 5,000 times smaller than those visitable bubble we see. And they circulate around the capillary, and the ultrasound will be able to visualize them. Just like this picture, you may not be able to see clearly because of the speed of the internet may be slow. Now, in fact, we can see the bubble, the micro bubble shown on the ultrasound. So this is the fibroid with the micro bubble. We are going from one side to another side of the fibroid. So after this, before we do the HIFU ablation. Now, after the HIFU ablation, we can see, for example, this area is the endometrium, and we can see most of the area that's supposed to be shown up by the microbubble no longer show any microbubble. Now, in this way, we are assessing that by our visual by eye is that there might be 80%, 90% of the fibroid being ablated. But still, I consider the way we are assessing is not accurate enough. That's why, for the time being, many in China, they are not only, they have done a pre-operative ultrasound to showing the blood supply of the adenomyosis, for example, this one. And one day after the HIFU treatment, they do the ultrasound again. And in this way, they will assess the amount of adenomyosis being ablated, like 80%, 90%. So in this way, and they will compare the success of the operation. But theoretically, with neural net, we are able to use computers calculation the microbubble and to be able to do exactly the same thing at what we are doing with HIFU. So this another area of development will save the expense of the MRI, which in Hong Kong, it costs us $1,000 American to do one MRI. Now, of course, the other application like placenta, accreta, cesarean section, scar, pregnancy, abdominal endometriosis are the application that focus ultrasound are doing in gynecology, have been well studied in some of the center in China. And I don't have the experience, but they are feasible. What impressed me is the future use of HIFU in cancer. My friend from Shanghai able to show me there's a case of leiomyosarcoma that keep on recurring. You can see the abdominal wound, there's so many scars already. Doctor doesn't want to go in to remove it, and because it causes another scar as well as long-term stay in the hospital for this lady. But the HIFU treatment, you can see they just a few hours, they ablate the leiomyosarcoma, even though it's not a curative method. But for this lady, the quality of life, being away from the hospital and without a growing leiomyosarcoma is much more than what they expected in a surgery. And then another lady with stage 4 breast cancer and ablation, and helped the lady just a few hours out of the hospital. Another lady with subcapsular, there's a cancer recurrent, HIFU can do the trick, even though not a cure, but palliative. I must share with you another lady that I've done together with Professor Janin. It's a lady who is only 35, and she complained of recurrent urinary tract infection and dysmenorrhea. MRI show she have adenomyosis. It extends into the bladder, causing bladder endometriosis. There's the cystoscopy. You can see the bladder endometriosis. My urologist consider if I just remove the bladder endometriosis while the adenomyosis is still there, she keep on recurring. So we use HIFU to deal with the adenomyosis of the uterus and deal with the border between the bladder endometriosis as well as the laboring adenomyosis. The symptoms improve a lot. There's no more recurrent urinary tract infection. It's our plan that she can get pregnant as what she wish, and so that during the cesarean section, hopefully we get the baby out, lower 7 cesarean, and then we remove the bladder endometriosis. We hope this is one of the early cases we can extend our so-called application of HIFU in complicated cases like that. The last thing I want to say, yes, I mean, waste contamination. In Hong Kong, we have 200 tons of medical waste every year. All over the world, in China, America, and India, they contribute up to billion tons of waste product or general disposal waste. And that's caused the problem. Incinerator and this unwanted disposal resulting in flooding, bushfire, mist in the city. So that's what we want. We hope we contribute to less medical waste. Finally, during this coronavirus epidemic, I learned one thing, is that the focused ultrasound surgery may be potentially useful for us to provide digital healthcare development in gynecology. Not only we can provide surgery using 5G, hopefully we have it in Hong Kong, and we can operate patients in a distance, and we can also teach people learning HIFU, and we can also monitor people HIFU to teach, to operate using digital surface. So I think that is one thing we should think of, that no other surgery can do that except focused ultrasound surgery. So it's not the end of the focused ultrasound surgery. It will be just the beginning. That's what I say. And like many people will say, disease that harm require therapy that harm less. That's what I put it in my clinic. And I welcome people to give me suggestions how we can advance focused ultrasound surgery in gynecology. This is my email address, and thank you for listening. Thank you.
Thank you. Thank you, Felix. Okay. Felix, that was a very impressive lecture, and I really, I'm glad that you brought up a very important point, and is that in HIFU surgery, we do not need to have blood to stand by, or we do not need blood transfusion. And this is very, very important, especially in this environment of COVID. I just caught what they said about sharks, and it really reminds me of those days when all of us were doing keyhole surgery, and many of our colleagues who are not into keyhole surgery will think that we are doing into something which time now becomes a recommended and accepted standard of surgery. So again, when it comes to HIFU, there's still a lot out there, I would say, who thinks the world is still a square, a cube, haven't seen the rest of the world and start commenting on practitioners learning HIFU. So it's very important. Also, the point which I'm driving home is whoever who embarks on HIFU, it cannot be see one, do one, and teach one. You really, really have to go through proper preceptorship, understand the subject, and with the correct mindset and culture, embark on HIFU. So I'm very happy you brought up these sensitive points. And I'm also happy that despite all the constraints you have in Hong Kong, I just gathered within a short period of 6 months, you've already done 50 cases. That's very, very commendable, my friend. Okay,
thank you.
On to the next speaker. Let me get my slides up. You see, different countries and different HIFU centers have different protocols. And I would like to share this because then we're hearing from somebody, Dr. Raymond, who has really done 5 years HIFU treatment on fibroids. And I would like to let all of you hear what it is like to be so far away from China and to be able to do HIFU. And he has, and I understand, he has his own protocols for the safety of his patients and for the safety of our patients, I think every center should modify the protocols to suit the safety and the practice of medicine in your region or in your country. Let me introduce Professor Raymond. Was born in Johannesburg in South Africa in 1954, graduated in medicine and surgery from the University of Witwatersrand in 1978. He's consultant ONG since 1986. He's the head of gynae unit at Chris Hani Baragwanath Academic Hospital since 1990. His main activity is gynecological surgery, oncology, and especially with pelvic floor prolapse. He's the head of HIFU unit since 2016. So he has done HIFU ahead of many of us. He's also the vice president of ISMIVS. And without further ado, let's hand over to, how come my slide is not moving? It's not moving. Sorry, my slide is not moving. Okay, without further ado, let's hand over to Professor Raymond Setzen, and he's going to talk about HIFU clinical application in South Africa for treatment of fibroids. Over to you, Raymond.
Okay, good evening, everybody, and thank you, Professor Lee and the organizing committee of APAGE for inviting me to talk at this very auspicious webinar. My topic is HIFU, clinical application in South Africa for the treatment of fibroids. It's not moving. Heather?
Center, Chongqing Scan Center, can you please help? Our team, Chongqing, please help.
It's not moving.
Okay, while Raymond is fixing the technicalities, can I just remind Selva, Dr. Selva, can you hear me?
Yeah, I can hear you.
Selva, I like your summary of the 6 points, the one-liners of the answers to your 6 questions. Could you please send me an email with the 6 pointers? I would like to crystallize them and make a grand summary. Can you do that for me?
Now?
No. After everything is over.
Okay, sure.
No hurry.
It's not for this webinar.
No, I will summarize it for the next webinar. I'll get a summary from all the experts because I still have to hear from Raymond, and I still got to ask questions on Felix, and I still have to ask questions of opinions from Pong and Dr. Gopinath. Are we ready to present?
Yeah, it's okay. It's working now. Okay, so I'm going to start my talk now. As I said, clinical application in South Africa for the treatment of fibroids. Just to show you on the map there, how far away we are from Asia, right at the southernmost tip of Africa. Just to give you a bit of information about the hospital where I work at, it's Chris Hani Baragwanath Academic Hospital. It's the largest hospital in Africa and in the Southern Hemisphere, and it's the 4th largest hospital in the world with approximately 4,000 beds. And this hospital services the needs of Soweto, which is a black urban settlement bordering on Johannesburg, which is one of our major cities. And we service a population of 5 million people. It's a government hospital, which is affiliated to the University of the Witwatersrand. It's the largest training hospital in South Africa. The majority of our patients are black patients.
Felix,
we have
the rest of you, are you seeing the slide?
Sorry?
I think the rest of us, I can't see the slide. I can't see the change of slides.
You can't see the slides.
Felix, can you see the change of slides? I can't see it from Singapore.
I just see the first front line, but no other slide coming out.
No change of slides, right? So Raymond, we don't see your change of the second and third slide. There's something wrong with the...
Let me try again. Can you see
Yeah,
now?
now it's moving.
Now
It's
I
okay
can.
now.
Yes, now I can.
Can you
Yeah.
see it now?
Yeah.
Yes.
All right, so
Now
I'll start again then. So as I said, we're very far away from where you people are. We're right at the southernmost tip of Africa. Just to inform you about my hospital, as I said, it's the largest hospital in Africa and in the Southern Hemisphere. And it's recorded as the 4th largest in the world. According to bed size, we have about 4,000 beds. And we service a population in Soweto of about 5 million people. It's a government hospital, which is affiliated to the University of the Witwatersrand, which is one of our 3 major universities in South Africa. It's the largest training hospital in South Africa. The vast majority of our patients, more than 99%, are Black patients. We have the only HIFU center in sub-Saharan Africa, and treatment for patients is free. There's no cost for the patients. This is just a picture of the entrance of our hospital. So when we look at the fibroid profile, in South Africa, we have a population of about 58 million people. And of that 58 million, 29 million of the population are Black females. And when you look at the prevalence of uterine fibroids, it's 3 to 5 times more common in Black women than in Asian or Caucasian women. So you can see that we have a big problem with fibroids. And the vast majority of our patients which present to our gynecological outpatient department present with fibroids and related complications. This is what our hospital looks like. It's overcrowded. There's always hundreds of patients waiting to be seen. So when HIFU came along, it was a godsend for us. Looking at our unit, we've started operating in October of 2015. I'm the only doctor, unfortunately, who does the HIFU. I'm assisted by 3 sisters, and to date, we've treated 460 patients. This is the machine that we use. We use the model JC200, which is from HIFU from Chongqing in China. Looking at our patient profile, our patients are a little bit on the challenging side. As I said before, the vast majority, in fact, all the 460 patients we've treated to date are Black patients. We have a big problem with obesity, and according to a survey done in 2017, they found that by the age of 20, over half of all South African women are overweight, and by the age of 45, this figure had gone up to 82%. Now, this is a problem for both traditional surgery, whether you're doing a myomectomy or hysterectomy, but it's also a challenge for HIFU. So it makes the cases more difficult to treat, and there's increased side effects. We also have a very high HIV infection rate. About 20% of South African women of reproductive age are HIV positive. And this is a danger to our medical staff during surgery. Patients, often with these big fibroids, we've got 2 or 3 assistants. There's lots of hands inside the abdomen, and there's a good chance someone's going to get a needle stick injury. So surgery is quite dangerous, whereas with the HIFU, we don't have this problem. Another problem with our patients is we have a very high infertility rate. Also, we have 9 different tribal groups, and from all these groups, we have many varied traditions and cultural beliefs. One of these is that in order for a woman to get married, she has to first bear a child. So marriageable status is related to fertility. And also, the more children you have, the higher your social status in your area. So there's an intense desire to preserve the uterus. So again, HIFU plays a vital role for us in terms of these patients. With the socio-economic issues, unemployment rate in South Africa is very high, and it's increasing on a daily rate. So this creates job insecurity. Patients are very nervous to come in for traditional surgery. To take off 6 weeks from work, they're worried that when they come back, they'll have lost their job. And also it's difficult to get sick leave. The employers are very reluctant to let them take off 6 weeks of leave. So they're not keen to have surgery. Another problem with our patients are they're late presenters. So they always seek alternative forms of treatment before they come to us, whether they're traditional healers, herbalists. So by the time they come to see us, they've got massive uterine fibroids. Another problem is they see an abdominal mass and then they suspect they're pregnant and then they don't go and seek any treatment. Also, our patients don't go for routine checkups. They will only come to hospital when they are sick. They also have a fear of hospitals and a fear of surgery. So as a result of all this, they present very late. And then when they do present, the uterus is it's large. They have massive uteruses with multiple fibroids. Here's some pictures just to show you the kind of patients that we see.
Wow.
Here's some MRIs of the uteruses. So we see very large multiple fibroids. And as a result, our patients also have extreme symptoms. So they have severe menorrhagia. We have a very high anemia rate, patients with severe dysmenorrhea, besides all the other symptoms of big fibroids. Another problem with our patients is usually fibroids will present at about 35 years of age. In our population, we see large fibroids as early as 18 years of age. And they also, at this early age, they also have extreme symptoms. So for us, HIFU plays a major role if you look at all those problems that I've just discussed now. Looking at the inclusion criteria for our patients, the four main ones are that the abdominal wall thickness should be less than 6 centimeters. We go up to a uterine size of 18 weeks. They must also not have major abdominal scars on the anterior abdominal wall, and they must be able to communicate with the doctor. We get a lot of patients coming from outside our borders that don't speak English or any of our African languages, and this creates a problem because the patients need to communicate with us during the procedure. The rest of the inclusion criteria there are the same as for most other places. In terms of exclusion criteria, well, as we mentioned now, if the abdominal wall thickness is greater than 6 centimeters, there's an increased chance of getting skin burn, so we won't treat them. If the uterus is greater than 18 weeks in size, again, we won't treat. Large abdominal scars, numerous fibroids. If the patient is desperate to fall pregnant and they've got lots and lots of fibroids, then we would rather recommend that they go for surgery. If they're not in a rush to fall pregnant, we will treat these patients with numerous fibroids. We'll just do it at multiple sittings. Intracavitary fibroids also is a contraindication because we don't want to damage the endometrial lining. If they've got large pedunculated fibroids with a thin stalk, again, we won't treat because there's a chance they can break off and fall into the abdominal cavity. And as I said before, if the patients can't communicate with us, we won't treat them. This is an example of some of the patients we see. Obesity with a very ugly scar in the proposed ultrasound pathway. This kind of patient we can't treat. So fibroids has a major burden on our healthcare system. And if you look at the traditional treatment, whether it's a myomectomy or a hysterectomy, they have lengthy hospital stay with overcrowding of the wards. At these procedures, if you're doing a myomectomy on one of these very big uteruses, often we use 2 or 3 units of blood. And in our country, blood is very expensive and it's a scarce commodity. And also there's a long waiting list for surgery. So we have a backlog at any time of about 450 patients, which equates to about 6 months. So the healthcare benefits of HIFU at our hospital have been to shorten the stay in hospital. It frees up theatre for more urgent cases. We have lower running costs. We have decreased exposure to HIV and a decreased dependence on blood. And the benefits for the patient are, well, obviously we preserve the uterus so they can retain their fertility, which is a very big problem in our population group. And also being non-invasive, the recovery period is much shorter and the patients return to work much quicker. Within 1 week, they're back at work as opposed to 6 weeks if they're having a myomectomy or a hysterectomy. So just looking at our results so far, to date, we've treated 460 patients. They've all been Black patients. The age varies from 18 up to 45, and the weight varies from 43 to 115 kilograms. And as you can see, the abdominal wall thickness varies from 33 to 64 millimeters. So the vast majority of the fibroids that we've treated have been anterior fibroids, intramural fibroids, and the vast majority have been hypo-intense on T2 MRI signal intensity. The vast majority of the uteruses have been anteverted. If we look at the patient's symptoms that they present with, 73% presented with dysmenorrhea, 71% with menorrhagia, 68% with anemia, that's an HB of less than 12. Infertility, 53%, constipation, 37%, and urinary tract symptoms in 35% of patients. If you look at the treatment time, for a small fibroid, a 2-3 centimeter fibroid, we've done it as quickly as 14 minutes. And some of the big multiple fibroids have taken up to over 3 hours. In terms of major adverse events that have occurred following on HIFU, of the 460 cases, we've had 2 cases of first-degree skin burns, which healed spontaneously on their own within about 2 weeks. They didn't require any skin grafting or any other management. We've had no bowel injuries. Now, with those big fibroid uteruses trying to do myomectomies or hysterectomies, very good chance you're going to get a bowel injury. The same with bladder injuries. We've had no bladder injuries. We've had 2 cases of nerve injury, which again resolved spontaneously within 6 months. They were not left with any sequelae thereafter. Now, the interesting thing here is we had 1 patient who developed rhabdomyolysis and went into severe renal failure that was irreversible and had to get a renal transplant. But on investigating this patient, it was found that she actually had underlying undiagnosed rapidly progressive glomerulonephritis. So it wasn't that we caused the rhabdomyolysis per se, we just brought it on a bit earlier. So all our patients, before they start treatment, and then again at 1 month, 3 months, 6 months, 12 months, and 24 months, fill in a health-related quality of life questionnaire. And if you can see here, before treatment, they had low scores, poor quality of life at about the point score of about 35, and how it slowly increased, and up at 24 months, it was already up to about almost 80. So there was a marked improvement in the quality of life in our patients. If you look at the symptom severity score, again, this is done the same as the quality of life. They had marked symptoms before the treatment, just below 60, and then slowly over time, up to about 24 months, it dropped down to just below 20. So there was a marked improvement in the symptom severity. Looking at the shrinkage rate, at 1 month, we were seeing figures of about 31%, which increased slowly up to 12 months. We only saw them up to 12 months initially, and we had about a 73% shrinkage rate at 1 year. So if you look at our fertility successes, we've had 16 cases. 8 patients are currently pregnant at the moment. We had 1 4-kilogram vaginal delivery, and we've had 7 term cesarean deliveries. One of the cesarean deliveries was a twin delivery. The reason also why we probably have such a low success rate is our patients they're very poor on follow-up. They don't come back a lot of the time I only heard about these cases from from colleagues who are in private practice. So very often we don't get to hear about their pregnancies. This is just a gallery of some of the babies that we've delivered. These are just some cases that I'll quickly show you. Here's a 40-year-old patient before the HIFU, and then 1.5 months post HIFU. You can see there's an ablation rate of about 98% and a shrinkage rate of about 27% already at 1.5 months. That's a 32-year-old. Okay, there's before. On the left is before, 4 months post HIFU. There was an ablation rate of about 98%, shrinkage rate of about 63%. This is a 27-year-old, ablation rate of about 71%, and at 23 days, the shrinkage was 8% at just under a month. In this patient, she had multiple fibroids. We can see that there's a good ablation rate in the posterior and the anterior fibroid, and the pedunculated fibroid sitting up on top only at 41%. They don't do well, the pedunculated fibroids. So in conclusion, we have found that HIFU is a safe and effective alternative treatment for uterine fibroids in our Black patients. The results have been very promising, and there's great potential for improving women's health, and it's made a huge improvement on the burden on our hospital. Thank you.
Thank you, Raymond. Yes, Raymond, I've heard your talk before when you gave a talk to a group in Africa, but it's always very entertaining, even to hear it for the second time, because you not only did you deliver a talk, number one, you don't heap on us all these papers, but you actually introduced South Africa to us, and it was the first time I see an outpatient department in South Africa. And you brought up a very important point, which, because the world is so focused on COVID, we forgot that there are patients with HIV, and HIFU definitely breaches the border of the risk of treating or handling HIV patients and COVID patients. So it's very good that Felix brought up COVID, and you remind us again of the presence of HIV patients and patients. Does your hospital accept foreign patients?
Yeah, we take foreign patients. As long as they can speak English, we will take them. So we get patients coming from Zimbabwe, Mozambique. We've had patients from Nigeria, from the Congo. We've had from all over. As long as they can speak English, we'll treat them.
So do you charge them? Is it still free for them, or you charge a fee for the foreigner?
That's a difficult one. What we do is yeah. So basically, we're not supposed to treat them for free, but we do treat them for free.
Oh, okay, sure. So we'll send you all our patients who have difficulty paying. Thank you so much. Thank you so much. All right. Maybe it's open for question and answers. Maybe I'll let my co-chairman, I don't know, and Gopinath, if you have anything to ask the speakers.
Thank you. It was an excellent webinar, and all the speakers were very good. And I would like to have one comment for each of the presenters. The first one to Selva. Selva, there are a lot of things just coming out saying that when you use harmonic for a myomectomy and then use multiple layer sutures and preservation of the endomyometrial junction is a preventive for rupture uterus. What is your comment and take on it?
These are what people talk about, but I don't think there is any paper that looked at this as a prevention for prevention of uterine rupture. These are all probably expert opinions on prevention. I think it's logical. What they're saying is logical, but to have a paper to address this is difficult, I think, and I don't think there's any published papers on this particular way of doing the myomectomy and the suturing. But it sounds logical.
Thank you. And my questions to Dr. Raymond. You have seen a lot of patients on infertility being treated with HIFU. There is a lot of publications saying that it does not alter or it does not deteriorate the ovarian reserve. What is your comment and what is your observation in your patients with infertility?
Yeah, look, we don't go near the ovaries, so it's not like embolization where you affect the ovaries. So we make sure that we keep well away from the ovaries, so there's no effect on the ovaries. So it shouldn't interfere with fertility. The problem in our patients is we have the infertility is multifactorial. We have a lot of pelvic inflammatory disease besides the fibroids. So, and we don't do any workup on those patients pre-HIFU. So we're not quite sure of the causes of the infertility, but we have found in those where the fibroids have shrunk that they have conceived. But yeah, there's no effect on the ovaries.
And another question to both the second and third speakers. See, I have done about, say about 2 years of my experience with MRI-focused ultrasound for HIFU with that Inside Tech. Then after that, it is just, we have stopped it. On comparing with that, this ultrasound-focused HIFU has got a lot of advantages. But however, you have to depend on MRI for pre-treatment evaluation, post-treatment evaluation, and then if you are going to establish a center, probably it adds up. Would you be more happier if there is some developments on ultrasound like 3D, 4D, spectroscopic appearances with which you will be done away with the MRI when you are using the HIFU system?
I think Felix can answer that.
Yeah, I think we should work on that. You are right, because MRI is really expensive, and the 3D and also the ultrasound, which use the microbubble and the non-perfusion area under microbubble, we can work out. I mean, hopefully they will be equivalent to that shown by the MRI. I think that's one of the directions of the research I'm doing in Hong Kong. So hopefully we'll have the answer soon.
Yeah.
Thank you, Chairman. Thank you.
Correct me if I'm wrong, but I understand now in Chongqing HIFU, they already have the software to merge the ultrasound image and the MRI image live as when you're doing the HIFU. So if you are looking forward to set up the new version of HIFU machines, I think it should be in the system already.
Oh, in fact, my system is from Chongqing HIFU, and the MRI incorporated into ultrasound, but there's still some limitation. The software is not completed yet, so it doesn't have auto tracking when the patient moves, and also the MRI is really the digital view as well as the AP view, and they do not correlate with each other. I'm going to let them know. Hopefully they will improve it. And for the new learner, it will be easier for them under the ultrasound have the MRI image to see where the target points are. So that's important.
Okay, thank you. Pong, do you have any questions?
Yeah, question to Silva.
Yeah.
And for uterine rupture after myomectomy, it is very common that when people who had entered into the cavity will require cesarean section. I understand that in your presentation, in one of the paper, you said that, that is not a cool feature that require cesarean section. So what is your view on that?
The data that we have, Dr. PM, is that they couldn't pinpoint any factors that precludes that we can say that it is necessary to do a cesarean section. That's what the 19 cases that they studied that had undergone uterine rupture, they had only 5 cases, I think 4 cases that had entered the cavity. The rest is not. So that they couldn't come to a conclusion to say that, okay, if the uterine cavity is entered, you will have to do a cesarean section. Or if you don't enter, you don't have to. But as you can see from the data itself, most people who do laparoscopic myomectomies, the chances of allowing them to have a normal delivery is lesser, far lesser than when you do open myomectomy. They didn't analyze in that particular, the first study, they didn't analyze whether the uterine cavity is entered or not. So I think it is very difficult because they're all retrospective studies, they are all meta-analysis. So it is all comes down to the surgeon's preference, the surgeon's confidence. And I think the general consensus is if you have entered the cavity, then you will probably be very worried to allow the patient to have a vaginal delivery. That's a general consensus. But in the study, they couldn't prove that. I hope you get that.
Yeah, I actually understand that, because why I asked the question is that you said also people are using the entry into cavity as the criteria for doing cesarean section or not, and I doubt very much about why, you know. So I mean, by entering the cavity, from doing a very deep, say, myoma, the only thing is the endometrium. My understanding is that probably the most protective area of the uterus is the uterine wall. So if you do a very deep myomectomy without entering into the cavity, as compared to do a myomectomy with entering the cavity, what will be the difference in terms of the rupture in subsequent pregnancy? I guess there's not much difference. Because I don't think the endometrium will actually protect the uterine rupture. That's my point. So that's why I don't think that entering into the cavity, it should be the crucial factor in determining whether the patient should have cesarean section in subsequent pregnancy. I think that's a very important concept or principle.
Yeah, that is an interesting point. In fact, in the 19 cases that they studied of uterine rupture, there were some that were pedunculated fibroid that had rupture. So there are probably more factors that are involved besides the depth of the entry of the fibroid. But as you know, uterine rupture is a major disaster. Many people just shy away from allowing vaginal delivery when you do say a deep-seated myomectomy. That's a conclusion that we can say from that study.
Okay, gentlemen, this is my take. We are all taught by our great teachers to watch out for the endometrium and not to enter into the endometrium. But frankly, if you want to do proper myomectomy and proper stitching, invariably, many of us are guilty of entering the endometrium. So I tried to look up the literature to see who mentioned this thing about entering the endometrium, and it's a taboo. I could not find any. So it could still be a myth that by entering the endometrium, the whole uterine structure is weakened. Bear in mind, we have done a lot of curettage, DNCs and all this, which has done worse things to the endometrium. And this thing about Whye have to be very careful, because people who propose Whye that was already 20 over years ago. You will take it to current status, better blood, better antibiotics, and of course, very active lawyers around. We have to think twice. more so when our family size is small. We only have 1 child or 2 child. So to take the risk of a ruptured VBAC, although the incidence is rare, but when it happens to that particular couple, it's 100% hit. So please bear that in mind. And I'm really, really happy also to learn from South Africa that, you should speak to the women group and the population group of the ministry that the social status of a woman depends very much on the number of babies you bring forth to the world. And this is one culture I just learned from Raymond. Okay, can I just go around and ask? I know I'm revisiting the last webinar. Can I ask Pong Mo, Dr. Yuen Pong Mo, what is your take of morcellation? Do you still do it in the back? Your advice.
Yeah, my advice, I think we should do morcellation in the back. And actually, I have been doing that since probably end of 2014. I've been using the back. So the reason why is, one is obviously, there's a preoperative difficulty in diagnosing sarcoma in common fibroid. Although the overall risk people talk about is not very high. But if you based on the best evidence, so-called best evidence from the meta-analysis, which was reported by the AIH, I can't remember the full name of it. And it said that among all the fibroid requiring surgery, so the risk of being a sarcoma is talking about 1 in 1,500 to 1 in 2,000. So that is not a very high rate. It's not. This again, to me, is just not a very unusual scenario. So anything we can do to try to protect that, I think is reasonable. The second thing is, in the past, we don't do that because we find difficulty in doing it. Because normally we are dealing with big fibroid, large fibroid. We have to use morcellators, knives, scissors to cut around so you will perforate the back. So nobody is doing it because technically it's very difficult. And you require multi-port rather than one single port. Right? So a lot of people are not doing that. Now we have the ways of doing it. Not difficult, right? And also we have different paths available to do that. Then we ask ourselves, why not? We try to do everything to try to minimize the risk. Say doing surgery, we try to minimize the risk. Doing morcellation, why don't we minimize the risk? So my view is I do morcellation as far as possible in almost all cases, not only in myomectomy, and even when I remove the uterus through the vagina, I still try to put them in the back.
Sure. Okay, I understand. So what is good about this webinar is we hear from the experts from all over, and the reasons why they want to do something and the reasons why they do not want to do something. So, well, the take-home message is there's no right and wrong. It's which you are comfortable with and which you think is safest for your patient. Coming back, Raymond, do you do the morcellation in the back?
No, I don't. I don't do any endoscopy.
Okay, sure. So
and also at our hospital, we've only acquired laparoscopic equipment about 2 years ago. So we still in the early stages of learning.
Okay, sure. Thank you. What about Felix? What about you? Do you do morcellation in the back?
For very big fibroid now, I do mini laparotomy. Just a 5 centimeter wound, I can remove big fibroid. Sometimes when we do laparoscopic and even the morcellator and all added together, will be quite big. And sometimes we even use a mini laparotomy to remove after laparoscopic extraction of the fibroid to remove it through mini lap. So instead of saving my time doing laparoscopic and more expense for the patient, I just do a mini lap and it worked well.
Okay, so which means that most of the time you do not need a bag. Am I right?
No, because sure. I use a wound protector and I bring the fibroid really up to the skin. Hong Kong lady is good. They are very thin. So okay. It's quite easy. And also when you macerate the fibroid, inside the center of the fibroid, there's no bleeding at all. So when you gradually move out, and hardly there's a lot of blood loss. I mean, yes, there might be 100 and 200 mil blood loss for very large fibroid, up to 10 and 12 centimeter. So I did for some of the very difficult case, and I may use that, especially nowadays, think like more than 12 centimeter, instead of doing it very difficult one, especially the T2. I mean, MRI show is a difficult fibroid sometimes. I may use mini-lab.
Okay, sure. Now to Salva, do you macerate in the back?
Yeah, yeah, sorry. Carry on, Felix.
Yeah. No,
Okay.
I thought, well, for small fibroid, which I can put in the bed, yeah, put in the bed, right? When I use the electric macerator.
Okay, sure. Salva, your take.
Okay, in principle, I would love to do my macerations in the back. I do that for a lot of my patients, but sometimes I get lazy. I must say that. You see a small fibroid and you put in a macerator and you just macerate it without the back. So my thinking is actually my thinking is not more for the cancer part, but for the parasitic fibroids, the spread part. So actually, the bigger fibroids I macerate within the back. The small little fibroids I actually don't bother to put in the back, and I just macerate it out. That's the principle that I'm following. So my thinking is I don't want to, by rotation of the power maceration, I don't want the fibroids to go all over the place. And if I think that fibroid, I can see them properly and I can macerate without it, I just don't bother to put it in the back. So that's the way I'm doing. So the bigger, it's going to take a long time, I would prefer to try and put it in the back. It's more difficult, but at the end of the surgery, I know that I've got everything out. Whereas a smaller one, I can see everything I macerate. Sometimes I don't waste my time putting it in the bag. And I don't use a simple bag like what PM uses. I use the more safe bag, which is actually quite costly to us, to the patient. So that is a principle that I'm following.
PM has got his technique of recycling some of these bags, and maybe one of these webinars you should ask PM to present his technique, his invention of using things that he can recycle around for one. I mean, I am referring to sterile bags. He recycles them. Okay. Okay. Well, let me ask you this question, Salva. How long have you been using the bag? How many years?
For about probably 5 to 6 years. I think I'm the first in Malaysia to start the more safe bag, and I think after that, Bernard has brought it to Singapore. So probably about almost 5 years, 5 to 6 years, when all these controversies have come up. It was a struggle at the beginning to put it inside the more safe bag, because that bag has got its own problems as well. But now we have got quite good at it. We could put it in quite easily and do the surgery. But it still takes an extra little bit of time to place the fibroid. The bigger the fibroid, the more difficult. Sometimes the fibroids are large. It doesn't fit into the bag. So I actually have to cut it with a knife into 2 pieces and then put one at a time and then macerate. So it takes a little bit of time. We only have one type, what do you call as pre-prepared bag, which is the Indian more safe bag. PM's technique, he teaches us in the Afghan, it is very, very good. But somehow when I wanted the bag, they can never find it. It's actually a bag that he uses a suction bag. When you take out a suction, that bag, he keeps it, and he does it very nicely. I do it on and off, but sometimes after doing for 3 hours struggling with a fibroid, and then you say, now I've got this fibroid to deal with, you become lazy. And then that's when you start. Even yesterday, I had one fibroid, which is about 6 centimeter fibroid. I just macerated without the bag. You have a principle, but you don't follow it. You know what I mean? So that's how I've been doing.
Okay, just to remind, gentlemen, just to remind all of you, you may see that about 100 of us has logged into this channel, but actually there are 1,000 people from China logging in. Please speak slowly. Okay, Dr. Gopinath, what about you? Do you use a bag? I can't hear you. No, Gopinath, you have to.
I agree with Selva. It happens to be a little bit of a long, tiresome end of the surgery. You don't want to just go back again and then try to do it and do a complete work with probably a wash and then make sure that you have not left behind. But however, it happens to be something like a small, we use a suction bag which has been just taken out, and then the sisters will make a tie around and just use it. We do not follow the regular endo bags.
So do you or do you not on a regular basis?
Yeah. No, not on a regular basis.
Okay. All right. Sure.
Not on a regular basis.
Yeah. It's good to know because across, different countries and different practices, I would like to know because that gives everybody, especially younger doctors, of the respect for each and every one of the practices in different countries, and we should not say condemn using the bag, or we must say that we must use the bag. It really depends on the individual. But bearing in mind, all of you great surgeons for the past 20, 30 years, ask yourself, how many times have you seen a leiomyosarcoma? In those days, it's not the bag. So sometimes I don't know whether we are doing it because it's fashionable or because some other countries are doing it and we have just had to toe the line. But again, please go back, think about it. And Selva, you said you want to prevent parasitic fibroids. I agree, but why didn't you think of it way before the leiomyosarcoma? Okay, sure, I'm just tickling you. Yeah.
Dr. Lee, what is your final verdict on the bag?
Can I make a comment?
In my practice, I don't use a bag. I only use a bag on two occasions. One is the patient's a lawyer. The second one, the patient has read YouTube and asked for it. Apart from that, I will tell the patient, I don't use a bag because you have to embark on a surgery on you. True to my heart, I think it's 100% not a cancer. Of course, we can miss. You may say I'm just lucky, but I find that when I try to use a bag, it was really like gymnastics to me, trying to feed which one goes to what. And in so doing, it may, in the learning stage, may have more injuries than using the bag. So I must declare, I don't use a bag. And also I believe the moment you cut into the fibroid, if it is cancerous, you would have upstaged the cancer the moment you cut into it. So using the bag, maybe you said the area of spread is limited, but you already have upstaged it. So that's my take. Okay, we are open for Q&A from anybody who is logged in. Anybody has any questions?
PM, Dr. Lee, there is a question here from Dr. Zoraida, a friend of mine from Philippines. I'm looking at the question. It says that, what is the recurrence rate of myoma after HIFU treatment?
I suppose if you are doing it in Africa, then genetically the recurrence rate is higher. But I don't think there's a consensus from Asia of the recurrence. I don't know. So I would say the younger ones, because if you're in the 20s and 30s, you have a myoma, the chances recurrence probably about 10% or more. But if you have a myoma when you're about mid-40s or 50s, then the recurrence rate is probably low.
I think the host has accidentally muted everybody. I think we should unmute.
Oh, yeah. Okay, again. No, sure. Unmute. So anybody can.
Hello. It's Ala from Jordan.
Mm-hmm. Yes.
I have a question.
Yes.
I have laparoscopic myomectomy on Saturday. She previously treated by HIFU. Is it difficult? Is the surgery? Shall I expect difficult surgery if the patient exposed to HIFU? So the patient treated previously by HIFU, the myoma, treated previously by HIFU, but it did not respond, or she has recurrence after 2 years. So I'm afraid that the surgery will be difficult for inoculation or something.
Okay.
The problem.
Yes.
Can I answer?
Sure.
So the problem after HIFU is that the fibroid becomes all soft So it's not easy to shell them out. It becomes all mushy, the fibroid, and your plane of cleavage is disturbed. So surgery is a lot more difficult after HIFU.
Okay, thank you. Thank you.
Oh, okay, my take, I have very limited experience of to repeat because I just started.
Thank you.
For the past 2.5 years, but on one occasion when I have to do myomectomy for a HIFU patient after delivery and after HIFU, it's because the pedunculated fibroid fails to shrink at the rate that the patient would like it to be. So I have the advantage because she had a previous Caesar. So I just did the laparotomy and removed the fibroid, which is about 8 centimeters. No worries, because what HIFU did is, I think HIFU is just causing shrinkage and atrophy. And depends on what stage you have to reoperate on the fibroid. Say, I think if it's within the first 3 to 6 months, it may be a bit soft. But anything that is more than 2 years or more, I think most fibroids will undergo a process of fibrosis and calcification. So there again, it would be the same scenario you probably face in a fibroid whom you have treated with GnRH or other modalities. But in your expert hands, I don't think you will have difficulty operating on a fibroid that has undergone or have been treated with HIFU. I don't know what the other experts think. I don't know. Are there any more?
Thank you for the answer. Thank you.
Thank you. Most welcome. Any more questions from, or there's somebody to say hello to Professor Wong from Philippines, I think, and someone wants the translation lectures. Someone's asked, Professor Felix Wong, how much does HIFU treatment cost in Hong Kong? But this person wants it in US dollars. Any more? No, unmute. Felix, unmute.
Can you hear me?
And now I
got
can.
4 levels of patient payment. Those who doesn't have any insurance, the amount of money is they pay for private in the clinic is around 10,000 US dollar. No insurance. For the one with insurance, and they possibly are paying 15,000 American dollar. So this is the range. So this includes everything, including the surgeon, the anesthetist, and the equipment, the cost of staying in the clinic. I think your price is more expensive in Singapore then.
No, Singapore is a poor country now. No. Hong Kong has always been charging higher than Singapore, so much so some of my colleagues asked me to go over to Hong Kong to work.
No, I mean, Hong Kong sanatorium will charge more for myomectomy.
That's
PM.
That's true. So the king is there, P.M. Yuen is there. They control. Okay. Jokes aside, can I just ask Felix? Can I ask Salva and Raymond, and especially Felix and Salva, and both of you are great laparoscopic surgeons. You believe in the art of laparoscopy. What attracts you to switch or to adopt a new technique called HIFU in your practice? Felix.
Yeah, I changed to HIFU technique because not only I don't want to do laparoscopic, I'm still doing laparoscopic surgery, but I think they give the patient another alternative. And that's what I want to explore. And also I find that this alternative may be more useful in various ways, which I have mentioned. So that's why I'm interested to change over. It's not change over, but now to move to another direction. And while just like in those days when we moved from open surgery, we are quite confident with it, but we moved to minimally invasive surgery or laparoscopic surgery. And this more or less the idea I have. So that's why I changed over.
Okay. Selva, over to you. You're already so busy, Selva. Why do you have another arm of surgery? What attracts you?
Okay, it took me a long time to go into HIFU. I still haven't started HIFU. The machine is in Malaysia, but because of MCO, we couldn't install the machine yet. I'm quite excited to bring this to Malaysia. Now, basically, I am a fertility specialist. I mean, I've been running IVF services for 22 years, so I'm always looking for better ways to try to help my infertility patients to conceive. So one of the areas that I realize is the borderline fibroids. Now we get infertility patients with fibroids of 3-4 centimeters, probably type 3, a lot of them maybe type 4, but just very near the junctional zone, which we don't know what to do. Now these fibroids, to do surgery on them, it's probably not a good idea. And to do IVF on them and help them to get pregnant, there is enough evidence to say that these fibroids will actually reduce pregnancy rates. In fact, I've written a review article which has been published in GPM, Gynecological and Pelvic Medicine, looking at these type 4 fibroids, small type 4 fibroids, and how to deal with them. And it's clear as at least type 3 and type 4 fibroids, small fibroids, actually reduces pregnancy rates. So I've looked at all the other options, uterine artery embolization, what do you call it, not myomectomy as well, plus SMIA, anything that can help to shrink these fibroids. And HIFU will be one of the best to do this. And I actually spoke to Professor Wong, and he said that nobody has done any work on this type of small fibroids affecting fertility. So this is the area that I'm going to concentrate on. The type of fibroids that surgeons don't want to operate, but we know that it affects fertility. So this is a good area. Of course, I also want to provide services for this group of patients who are frightened to do operations or multiple. Previously, I've done surgery and then we want to shrink it. Those are the standard, but this is one of the areas that I'm very interested in, and that kind of triggered me. Say maybe I should get into HIFU to look at infertility in a different area. Of course, the other big problem even today I saw is this lady who is 35 years old who is suffering severe pain and dysmenorrhea with adenomyosis. With big adenomyosis, that we don't know what to do with them. And I think next meeting will be talking on this. And this is another big area in infertility that all infertility specialists don't know what to do. We can collect the eggs, we can create the embryos, but the uterus is not good enough to implant. So if we can shrink it with HIFU, then they get a very good chance of pregnancy. So these are the two areas I'm looking at.
Thank you. Actually, gentlemen, one of the things I realized while I'm doing HIFU now is we provide those ladies, especially younger ones, to stop the growth of the fibroid so as to retain their fertility, and so as to for the older ladies not to lose a womb. So actually one of the reasons why I talk about HIFU is I've seen so many times the fibroid grows 1 cm by cm every year until it becomes 10 cm, and somebody says, do a hysterectomy. But what we're trying to do in HIFU is to stop its growth in its track. Okay, Raymond, what attracted you to HIFU?
Well, as I mentioned in my talk, our patients are very resistant to surgery. So as soon as we mention myomectomy, the patients have to sign for hysterectomy in the event of an emergency if we can't stop them bleeding. So they all refuse surgery, and they just keep coming back having bled out, requiring blood transfusions. So for me, this was a another alternative treatment for them, which I'm finding is working very well.
Yeah, for a good cause indeed. For a good cause indeed. So before I end, I just realized I remembered Selva has a little video clip, and all of you have presented very well, but the rest of the doctors who have never seen HIFU will not understand the process from the moment the patient walks in to the moment the patient walks out. So I will run that clip, and Selva, could you please comment on it, because I think you have this video clip. Over to you, Selva, your commentary. This was from you.
Oh, it is actually not from me. It's actually from Chongqing, but okay, I will just give the, it was taken while I was there trading. So you can see that this patient has come in, she's being prepared in the room, and so the preparation is done, and the patient lies down for the HIFU procedure. She's already had the drip up, and some sedation has already been given. And the HIFU specialist is looking at the MRI of the patient. And after looking at the MRI, he will start the treatment. And you can see that this is a transverse version of the MRI treatment. And then you can see that the patient actually is talking to the specialist who's doing the treatment. And this is a big advantage of HIFU. I think all the other speakers are doing this. I've just gone for training. I've not started doing this. But as the HIFU is being done, the doctor can talk to the patient, explain to the patient what he's doing, and ask her whether the treatment is painful. And if it's painful, then we can top up the analgesic. And you can see that he's talking to the patient. And there's a nurse also talking to the patient. Most of them are very alert. And so here the video shows that once it's finished, the patient actually walks out of the room and not wheeled out. So that is how HIFU treatment is done. I hope I've done a good job, Dr. Lee.
Okay, thank you very much. I'm glad you share that with us. I also just remembered I am supposed to do a summary. Back to, let me get my slides. I will do a summary of Professor Chang Lian's talk last visit. Normally, I would like to summarize the opinions of all the laparoscopic experts that appeared in the previous episodes, but I would like to hold it till I've heard from all the present panel of specialists and speakers, and then I will crystallize all the pearls of wisdom and put them together in the next episode. This is what I was requested to do by some of the, it doesn't move. Chongqing, can you please help? The slide doesn't move. Okay. This is a summary of what Professor Chang Lian said in episode 2 for those who requested for the summary. The number and size of fibroids that one chooses to perform HIFU, which is what we know, and FUAS, which is full focused ultrasound ablation surgery, which is better known as FUAS in China, are dependent on the doctor's skill, experience, and the expectations of the patient. Fibroids respond well to HIFU ablation. Results are good in terms of shrinkage and symptoms. Complication rates are very low and less compared to conventional surgery. Next slide. Pregnancy outcomes after HIFU have been favorable. So far, no uterine ruptures has been reported in pregnancy. MRI images are the best at the moment to diagnose leiomyosarcoma and endometrial sarcoma. In other words, if there's a basket of investigations to do and you have to choose one, he thinks still is MRI images are the best. Again, he added, you must have a high index of suspicion and MRI experience in analyzing images are required. If in doubt, it is best to treat by conventional surgery. And lastly, when he was asked, any harm if HIFU was used to treat an undiagnosed leiomyosarcoma unintentionally? The answer is a very affirmative no, because HIFU is used to treat cancers of the bone, liver, pancreas, and many other cancers. As an afternoon, I spoke to him, and Professor Zhang Lian has kindly offered to read suspicious uterine MRI images of patients of APAGE and ISMIVS gynecologists as a second opinion. So that this is a very generous offer to a very busy teacher. So if any of you have any suspicious fibroids, you can send to him and he will gladly read them and analyze them for you. Are there any more questions from the floor? If not, before I say goodbye, I would like to introduce the next episode. Next slide. The next episode is a special spotlight on adenomyosis and infertility. And for those of you who are doing infertility, IVF, this will be very interesting to you. And for those of you who are thinking of starting on HIFU to help with pregnancies, fertility, this is very, very important. And I have invited my co-chairpersons, is Dr. Rally from Indonesia, Surabaya, and my two friends from Europe, whom is a familiar face to you will be Dr. Hugo, is very knowledgeable man, and my new friend, Professor Gill from Austria. He is looking into having his HIFU machine. Again, these are people with who has done university practice and are now in private practice. So their values and their pointers are very important. From Bangkok, from Thailand, I have this young man, Dr. Ulrich, very enthusiastic, very knowledgeable, and a friend from he has friends from all over the world, and he's going to give a talk on adenomyosis, the tip of iceberg infertility. Last but not least, a very graceful lady from Shanghai. She's Professor Aising Aili. She actually became the head of the HIFU department in Shanghai and brought up to new heights in Shanghai. And she says HIFU is a spring to many of her infertility patients, but HIFU, to me, where she is concerned, she's the answer and the spring to her department in HIFU Shanghai. So that will be on Thursday, 23rd of July. For those of you who have doubts on HIFU and adenomyosis, please ask all the questions, join the webinar. Next slide. Some more? No more? Okay. I would like to say thank you to all you chairpersons, panelists, speakers, and audience for giving me face. The Chinese way of giving me face by coming on to this webinar. I'm Dr. Lee from Singapore ONG Group, and a big thank you. Just to show you, I come from a group of private specialists. There are 15 of us that covers ONG, pediatrics, and dermatology and cancer specialists. And after showing this slide, I will still get my pay for today. Otherwise, they will be very angry with me. So next one. Thank you very much. Goodbye. Goodbye. Thank you, friends. So I see you in 2 weeks' time.
Bye.
Bye.
Okay, bye-bye, Kinwai. Bye-bye, everyone.
Okay, bye-bye, everyone.
Bye-bye, everybody.
Bye-bye, bye-bye.
I've been to South Africa. I love to see the animals.
Thanks very much.
Okay. One more thanks. Felix, thanks. Saba, thanks.
Bye-bye.
Thanks, Taipei.
Thanks, Zhang Lian. 谢谢, Zhang Lian.
Thank you very much.
Thank you. Thank you. Thank you.
Good night.
Go for your dinner or late dinner now. Go and rest. Saba, don't forget your 6 pointers. Your 6 pointers.